Good afternoon. I would like to spend like maybe 15 or 20 minutes on the topic of challenge for transition to adult HIV treatment service. So I'd like to begin with the first questions. How old is the perinatally HIV infected individuals in your clinical care? A is 15 to 18, B is 18 to 24, C 24 and 30, and then D more than 30 years. In your own care. Okay, so you can see that majority is 18 to 24, but some are even above 30 years. And then I think the factor is that the first factor is how old are you, right? Because you're old enough, you will have patients that is old too. And the second one is on whether these patients access to treatment early in their life. And the third one is whether they are slow progressor. Because if you can find someone slow progressor that might be start treatment when they are 10 years old, so now they are become in their 30s. So do you comfortable to seeing them when they are growing up, or you would like to transition them to adult service? This is one of the questions, and that we should think about what is the proper services and about how we're taking care of our patients. So this is the data from US, and this one is quite interesting because in the US, they have register system. So once you register as perinatally HIV infected, there can be follow-up in the long term. So in this paper, it's showing that the oldest one in this report is up to 37 years old among about 10,000 perinatally HIV infected in US. And also because they register everyone, so it's not bias that you will show only the viral load among patients that it's still in follow-up. So they will calculate number for all patients that register, and it showed that only about 50% of them had viral suppression. And when they are in young adult, it's a period that they may have not continued treatment and have poor virological suppression rate. And how about in the US? And this is data from TAPHOT that was funded by Treat Asia that have 5 sites in Thailand. And then we try to plot using the same approach that we plot the age of everyone that was registered in the database, which is about 2,000 people. And it's showing that on average now in Thailand, the average age is also between 18 to 24. And the blue one is that the group that still follow up on the pediatric clinic, and the red one is the one that already transferred to adult service. And you can see that about 2/3 of them already transferred to adult service. And there are 2 types of service. At Chiang Mai, at Chula, about 50% is still in a pediatric care, in which it doesn't mean that pediatric care, we provide pediatric. In the pediatric department, we might already transform ourselves to provide adolescent care, but within pediatric healthcare workers. And another type is transfer to adult service. So the second question is that if you are the patient, imagine that we are perinatally HIV infected youth, which model you would like? A is standard. Care providers say that you have to move from pediatric to adult. B is that same clinic and healthcare workers have to transform themselves to care for everyone. And C is youth-friendly transition, is that adolescents themselves will be decide when they're ready to move. If you are the patients, which model you would like the most? Oh, interesting. So the most is like that you are listen to your patients or when they are ready. But in reality, I think majority would be number A, which is when the system asks that you need to move. So what is the transition model that we should look for or we should create? So the transition models, it depends on how you think about physically. You can think about physical transfer adolescent into adult service, or you can keep them in the clinic but transform the way that you care for the patient differently between pediatrics and adolescent. And it could be thinking about if you physical transfer the system in adult, you have to admit that in adult there are much more patients, so it's overburdened. and it was considered as depersonalized. It has less time to talk about people itself, but more on the disease, and maybe a bit more judgmental than in pediatrics, that we allow for trial and error for adolescents to maybe sometimes not be able to strict on the advice or on the appointment. And the attitude of adolescent is to feel quite afraid, alone, or be unprepared if you have to go directly to adult service. In the Western settings, like in the US or in Europe, they have adolescent clinic that they have transition, but I think it's not quite happen in Asia at all. For every disease that we have a specific adolescent, so we have to jump from pediatric to adult. And I think the important thing is that it depends whatever model it used, but the key or the heart of the successful is on the transition coordinator team, because it's someone who makes sure that patients still under the care, even at pediatrics or adult, or can go back and forth and have flexibility between transition clinics. And there are many models of how to do transition, like in Chiang Rai, they would do group transition. So to make sure that they have some peer support or someone familiar as a group from pediatrics to adult, which I think at the end we can ask Chiang Rai to share about this model, and it have been done in the past 5 years. Or some programs mentioned that we should bring caregiver to be involved, even though we think that we would like adolescents to be independent and taking care of themselves, but if we have caregiver support in the transition process, it might be more successful, and make sure that if you have something happen or problems, there are some family members to support. And the youth-friendly service that we should create, whether it would be among adult service or within pediatric service, is more on the availability that have integrated health service to include two important components, which is mental health and sexual health, because youth cannot come to clinic frequently in order to get each service. So we should integrate it, if possible, in one single visit or one day. And then have accessibility that allow to have more flexible time, like clinic in the evening or maybe during the weekends. Have acceptability that there are no stigma, and have peer support or adolescent activities. Most of the interviews and qualitative research, they say that the component is not whether this is cared by pediatrician or internist, but they would like to have some kind of adolescent activities built in that they can feel not too serious, that come to pick up medicine or get blood tests, but have something that engage them as adolescent activities. And also the last one is on the no discrimination of age, sex, education level, or social status. Because we know that when they are into adolescent, they might have some variability in gender and sexual identity, and some might be successful in school and some are not. Some has a job and don't have a job. So if they feel like comfortable that we accept the way they are, it more engage adolescent into the clinics. And also the one thing that is very sensitive is that we shouldn't differentiate whether they have viral suppressed or not. Because usually if they are viral suppressed, we feel like they are okay, and then we keep long interval of follow-up, and then something happen. Or sometimes if you have virological failure, we don't keep them follow-up more frequent, and they are very stressful, because sometimes it takes time, not just month or so, to change the behavior, maybe a year. So as long as they have no opportunistic infection, we should be not so judge them by the virological suppression. And what is the criteria to transition to adult service in your mind? If you have to choose only one criteria, which one you would like to choose? The first one is age of medical care system that allow them to be in the pediatric. B, if they're pregnant, when you're pregnant, you are like become suddenly adult. Or demonstrating independence. And D, complete all the formal transition training that was provided. If you have to choose only one criteria. Okay, so it's sometimes because of the system that need to change, and I think majority choose the C, which is demonstrating independence, and how to assess demonstrating independence, that it's hard. And what age do you think that adolescent is independent? don't know. I think now, at the beginning, we have discussion about transition in the previous conference, and we talk about 18, 21, and then many literature or many settings is now moved to 24 as a period that you are quite more confident that they are more independent. And this is the nice review which is published in WHO policy about how to think about transition to adult service. And the definition is that it's a planned process by which adolescents and their caregivers are empowered with knowledge and skills to enable them to be independently manage their health. So I think the important thing is that how they can be independently manage their health, not just the age, not just the knowledge about HIV, CD4 viral load, but more on the skills of how to be able to taking care of their own health. And the transition process is quite long. In the past, we talked about 6 months, 1 year of preparation, but actually in this paper, they said that actually it's begin after you disclose HIV status at around teenage. Because one of the reasons that you disclose is to involve that person to be participating in manage their own health. So that is the starting point of how they see disclosure as a starting point of transition. And then until they are be able to be independent at 25 years old. So in this paper, they talk about transition period as a period that can be long as 10 years. And they're saying that at the beginning, we start to think about transition when they start to think about disclosure, which is 14 years old, and prepare the patients in terms of HIV literacy, self-management, communication, and then along the way, we start to talk about who will be the adult service that we would like to transfer them. And then the important thing is that the flexibility between pediatric, adolescent, or adult care, that they can go back and forth in this loop. So I think the important thing is that it doesn't mean that they have to go to adult immediately, or if they have problem with adult care, they can go back to pediatrics care, as long as they can engage to any medical care that is suitable for that period of time for them. And it could be range about 10 years period of transition. And the component of the transition is start with disclosure of HIV, and then the pediatric and adolescent care, involvement of the parents or caregivers, and then add 2 important components for adolescent care, which is the sexual health and also the mental health in the picture. So it doesn't matter who give a care, but make sure that we have these 2 components in adolescent service. And this is also a good reference about the practical approach for transition. They put into 3 steps. The first one is communication about the process that would like to about to start about transition, and then during the period of transition, we evaluate whether they are ready, whether they have enough responsibility to do that, and also they have a right to decision whether when they are ready. But actually, in reality, sometimes this happens because the system changed. And most common in Thailand is that if the patients work, they would change the health insurance scheme from NHSO, which is the National Health Security Office, that they can get HIV service from any hospital, in the government hospital. But once they work in the workforce and enrolled in the Social Security Office, they would go directly to one hospital that they are registered. And the hard part is that you don't know which hospital, because you will know when you get a job and then register to that hospital. So it have very limited time to make a relationship with the new hospital system. So the one that is very important is that communication after transition. So they recommend that we should confirm that adolescents still in care and also be able to continue. And if not, we should have one coordinator to maybe bring them back to the pediatrics clinic or the clinics before they transfer, and then help them to successfully continue to the next clinics or the healthcare settings. And this is the examples of several steps that was demonstrated. This is the example from the Happy Teen model from US CDC and Siriraj and Children's Hospital, that they have a camp or process or curriculum that you can download from the website about how to prepare transition. And you can see that the module is not just the health knowledge or HIV literacy, but they also talking about the skills, coping skills, communication skills, negotiation skills, or life goal in order to prepare that they can be independently manage their own health. And the transition readiness assessment, this is example from the US settings, that in the US, the median age at transition is around 21 years old, and not all is successful transitions. Many of the adolescents still in the pediatric care. But interestingly, the readiness assessment is not focused on HIV, CD4, viral load, or opportunistic infection, but they focus on 3 things: self-management, can get prescription appointment, self-advocacy. For example, if they need to change the appointment due to other commitment, they be able to contact, ask to change appointment or negotiation with healthcare workers, or be able to manage themselves if they need to go to school, to work. For example, the most common reasons when we ask about the adherence, they said that I try to take medicine every day, but it's conflict with my work time, and I cannot ask my supervisor that this is my time to take medicine, so I decided to skip and wait until I go home. So all of these skills to advocate that this is I need to do, and I would get around of other situations to continue taking medicine is one of the skills that we should make sure that the patients can do that. And the last one is on emotional and social support. And this one is on how they can be able to keep contact with the previous team or pediatric teams in case they have some emotional problem or psychosocial problems, that they can rely on someone to help them go through the process. So this is the parameters that they assess for the readiness, and find that this is strongly related with the continuation of the treatment among transition group. And this is the review literature on the transition to adult care for every disease, not just for HIV, in general concept of transition from pediatric to adult. And the group of the barriers, that is the barriers for transition to adult care, including the relationships with the new team, believes that it's difficult or it's lonely to transition. So we need to prepare them and address their belief, anxiety, or concern. The skills to navigate to healthcare system, the new one, or the skills to make sure that they can get drug supply without interruption. Because many of the patients have relocation due to education, job, or family, and they don't know how to start to get connect with the new healthcare settings or hospital, and then they decided to stop treatment. And the last one is on the insurance, that have to make sure that it's support. And how you monitor after transition, how do you know that the transition is successful? In this paper, they are try to quantify the successful of transition. They are divided into 3 parts. The first one is to linkage to care. So the definition is that within 3 months after referral, they have at least 1 clinic somewhere else. Second is that retention. Over 1 year after transition, they should have at least 3 medical visits to make sure that they are retention in care. And the last one is to make sure that viral load still have viral suppression. And also the quality of transition process, to have experience after transition, and also the social outcomes. So this is an example of South Africa. I think we might be struggle that we are so busy with our clinics. How come that we can be able to follow someone that we already transferred, because we have new patients come in. So in South Africa, they use the database, in which in Thailand we also have national HIV database. So they go into the database and track whether the patient that already transferred had continued treatment. And interestingly, that South Africa, the transition age, it starts at 10 to 14 because of their medical system, that at 10 years old, they need to transition to another service. So in that paper, they're showing that the retention using the linkage from the cohort is about 84%. you could see that 84% is a good number, but it means that about 15% of them lost. So the important thing is how we can have a system to get 15% back to service, and how we can communicate to this population, because they are the ones who will have high viral load and be able to transmit to their partners or their peers. And this is data from Treat Asia study, the STAY study, that have a strength that they have a qualitative component evaluation of process of transition, not just only the number. So they asked participants from Thailand, Vietnam, and Malaysia about outcome after transition. And the protective factors for successful transition is feeling prepared for transfer, and also be able to meet pediatric providers sometime after transition if they need help. And they still feel quite, the challenge is that the social impact about HIV that they need to face when they are growing up. So this is all the information that we should be addressed when they are transitioned to adult. I have two short examples of the adolescent in our clinics that have transitioned. The first one is 22 years old male, perinatally infected, and they start treatment since 6 years old, have viral suppressed all the time. And after 18 years old, he moved out to live with his girlfriend. He no depression, he functioned quite well. And at age 22, because he had a job, so he changed to Social Security office. At the time before transfer, have viral suppressed, take antiretroviral drugs that is very simple to find in every clinics. So how you manage the transition? Because it's abrupt transition due to the change of healthcare system that these patients have to move to the new clinics. So this one, we assessed him before we move him to the new clinics. He already know about HIV for a long time. He have quite managed himself, keep appointments, good viral load, suppression all the time. He said that he had a bit anxiety because he don't know how to deal with the new team, because he be in this clinic for more than 10 years. So what we did is that we have a peer navigator to attend the clinics together with him. The first clinic, the peer navigator bring him to the new clinics. The second one, peer navigator go with the patients, but ask the patients to do by himself and just like make sure that go for support him. And the last visit, patient go by themselves and then follow up that they have no problem. Even though we have that kind of handover, and another thing is that we have a spare medical supply. We have like 6-month medical supply with him in order that this process is not successful, to make sure that they still have a continuity of medications. However, he stopped ART for 3 months because he said that it's too difficult to get to the new place. And then he contacted the peer navigator to ask him to supply him for another 6 months of ART and then reconnect to the adult service again. So I think it's, even though they're quite ready, they're old, 22 years old, but this process is not that easy. So the key message is that you have someone there to make sure that if something happens, we can be helpful to encourage him to transition again. Another person is 23 years old, transgender. This one, he is sick. She is sick at the time of transfer. Perinatally HIV start ART since 7 years old at CD4 of 3 cells. On multiple drug regimen, have multiple drug resistance, receiving darunavir and raltegravir. She would like to be transgender. She take hormones and also have some breast surgery. And then after she moved to live with her boyfriend, she need to relocate because of the family. And then she started to not taking medicine properly. And the medications that she take is also difficult to find in other provinces. So what's happened in this case? We lost of contact of her. And then we get a phone from the hospital that she have some conflict with her boyfriend and had suicidal attempt and was hospitalized in one hospital. But she had a medical history summary from our hospital with her. So that hospital is contact us back and then ask for some help. So I think one message is that if you think that it might happen to have transition, one thing is that you have to have medical records with the patients all the time. In case of something happen, they can link back to the primary care team. So the last part is that what patients think about. This is the interview that was done about 5 years ago when we do a focus group, ask adolescents about the transition process. And this is the voice from the adolescent. They say that for the pediatric healthcare providers, we need your help in preparing us, and we also would like to be able to get in touch whenever we want, because it's quite uncertain whether we will success in the transition process, and we would like to come back to pediatric clinic if needed. And please don't threaten us with the adult clinic. If we don't take our medication accurately, don't say that you must send to adolescent or for the adult service. And for adult healthcare providers, I'm not sure whether any in the room, but they said that we need opportunity to learn. We are learning, but it takes time to be able to perform well or be able to maintain our health care management. They would like to have staff available to ask, and if possible, have adolescent clinic. It could be in adult HIV service, but maybe set up some time, like once a month, to have adolescent clinic, so they can have someone in the same age, at the same situation, to share or to be friends. And also would like to have activities arranged specifically for young people to help them adjust to the adult life and also the new system. So I'd like to end that in terms of transition to adult service, it's not just easy. So it's just not jump from one clinic to one clinic, and it could take times and preparation and support to the process. And also the ultimate goal is transition is not because the pediatrician would like to go out of the job and send all of the patients to adult, but ultimate goal is to make sure that the patients that we see for more than 10 years or 15 years be able to manage their own care and have good health and well-being. And also I think the important part is to prepare them, evaluate whether they have ready or not, and also listen to them, and they have a right to stay in the clinics until they are able to manage their health and ready to transition. And also warm handover between teams, which sometimes is difficult because we don't know which team they would refer to, but have someone who be a coordinator to support it. It shouldn't be nurses or doctor because we are too busy, but if you have some case manager, it might be the solutions. And I think what we want to see is that our pediatric patients that we see from very young be able to be taking care of their own life. And I would like to acknowledge our teams at HIV-NAT, at Chula, and also Treat Asia to create some activity in the past 5 years around the transition process. And this is the photo that we take from the camp, and we do it from a camp for adolescents. And I think to myself, what I learned in the past 5 years is we learn to listen to the adolescent, we learn with them, and also we transform our service to meet their needs and also help them transform themselves to be competent adults, to be able to taking care of their own health. Thank you.
Thank you very much for address the important issue on this. So I think we have 5 to 10 minutes to for your question or any comments. So if you have any question or comment, please come to microphone, or you can raise your hand and I will go to.
Annette, any suggestion in your point of view of the transition in Asia?
Thank you, Thanyawee, for your presentation and such a nice overview. I think what you showed earlier from the Treat Asia data of the Thai sites of how many patients have already been transferred at Chiang Rai, in particular, where Dr. Bai Plu is, but almost everybody has been transferred out. And so many of you may not be from these sites, or maybe in your countries it isn't like that yet. But that's coming. And as we eliminate mother-to-child transmission, as has been done in Thailand and Malaysia, there are going to be fewer numbers of children. I think PMTCT coverage right now is very weak in Indonesia, but in other countries it's getting better. And so I think that this is the reality for all of us, and I would encourage people who are not yet going through the transition with their patients to contact the Thai experts to get some advice about how to do this. Some of the slides included different art images from a Treat Asia transition flip chart. So we actually have on our website a book to help guide with transition that you can use with your teenagers. And if anybody's interested, feel free to contact the HIV-NAT organizers. They can forward your questions to our team and we can send you the link, but it's available at the Treat Asia website. You're welcome to download it and use it. Thank you.
And can you share about the experience from Chiang Rai that you transition most of the patients out? So you transition to adult clinics in Chiang Rai Hospital, or you transition them throughout the countries as whatever their life changed to? Because I think Chiang Rai is one of the most oldest cohort in countries, and a big cohort, about 500 pediatric patients.
Thank you, Ajahn Thanyawee, for letting me sharing the experience.